All patients have their ups and downs. Every once in a while you get a patient who seems to be, for one reason or another, having a more of a roller coaster trip, particularly around specific areas such as LDL or hypertension. One of the most recognizable figures in hypertension research and many other different areas is Dr. Prakash Deedwania from UC San Francisco. Thank you very much for dropping by. The topic of visit-to-visit variability, you were specifically focusing on blood pressure, correct?
Yes.
What did you learn?
Well, what we found in a very large database, we had two presentations here, one yesterday, one today. Today's presentation was a compilation of about almost 19,000 patients from three large trials, the TNT trial, the IDEAL trial, which were both trials in patients with coronary artery disease, statin trials, so they were not hypertension trials.
Right.
And then we have the CARDS trial, which was a diabetic patient without previous cardiovascular disease for primary prevention. So I have been aware that the blood pressure variability is an important and independent predictor of cardiovascular events, particularly stroke, but also of coronary events. So I was very curious. I said, well, if it is, why does one have to really go to obvious hypertensive patient? Why don't we go to the population which is not selected for hypertension? So that was my interest. So I went to this very large cohort of patients, and we were fortunate that in all these three trials, we had 4 to 6 blood pressure reading over the duration of the study. So we selected those patients only within these trials who had at a minimum 4 blood pressure sequential readings, and then we looked at their visit-to-visit blood pressure variability. What it means is that if you look at a given patient blood pressure on visit 1, visit 2, visit 3, visit 4, and then you look at the standard deviation of the systolic and diastolic blood pressure between those visits. So that's the simplest parameter, essentially standard deviation of the blood pressure. Then you can look at if these people are different, those who have higher variability visit to visit versus those who have lower visit-to-visit variability, which is what was shown in the previous studies by Rothwell, by Peter Sevier, and others. So we looked in this database, and we found indeed that, first of all, there are patients who have various ranges of blood pressure variability, some less, some more. So sort of looking at the deciles of the blood pressure variability in these patients, and then trying to see whether this has independent value above and beyond what we get with good old blood pressure value itself, systolic and diastolic blood pressure. Long and behold, we found that in this not hypertension selected patient population, we found that blood pressure variability, particularly of systolic blood pressure, but also of diastolic blood pressure, was highly predictive of the risk of stroke, but also of coronary events in the two large CAD cohort in the TNT and the IDEAL. For a stroke, it was not as predictive in the diabetes study, the CARDS trial, but it probably, in my opinion, is a reflection of lower events because these were patients for primary prevention. They don't have identified vascular disease, although we consider diabetes as a vascular disease equivalent. And then we'll put the data together. So when we put this 18,000 plus patients cohort together, we found that yes, both systolic and diastolic blood pressure variability were highly predictive of the risk of stroke as well as coronary events.
Is there any blurring of the data due to the fact that maybe the blood pressure was taken differently or different people will get the different readings?
Of course, that's one of the drawbacks anytime you have a post-hoc analysis of the database, but clearly there wasn't concerted effort in these trials to define as to what time the patient will make the visit, and I'm fairly certain that the visits were almost always at the same time. Why? Because these patients came for these visits in a fasting state. So they had to come at a certain point in time, mostly in the morning time. So the times are probably constant. We also have provided many of them with the standard technique or device to take blood pressure. So I think it's probably as standardized as one can, but obviously prospective studies need to be done to look at this.
In this meeting, there's talk also, but there's a presentation analyzing data from the TNT, treating to new targets.
For LDL variability.
With LDL variability.
Shripal, Bangalore, and that.
It's essentially the same thing. It's
exactly
a factor. Are you convinced enough now that if you are seeing a patient who has visit-to-visit variability, whether it's LDL or blood pressure, to consider that an extra marker of risk?
Well, I think there is a very simple message in both of these studies. And the simple message is that these people who have variability in either blood pressure or LDL, they are different. They don't have the homogeneous control or homogeneous levels of these biomarkers. And for whatever reason, they are different and they are having fluctuation. For blood pressure, it's easier to explain, and that is, they, like in the study done by Rothwell, one of the group was with prior TIA. Maybe they have altered central regulation of blood pressure. There are other mechanisms that could be playing a role. Drugs play a role. Certain drugs, such as calcium channel blocker amlodipine, has a much better 24-hour control. And in the ESCORT database, it was shown that amlodipine had much lower blood pressure variability as compared to atenolol-based antihypertensive regimen. So I think, and for LDL, it's a little bit more difficult to sort of relate it in a pathophysiologic manner, but I think LDL variability is probably reflective of that these patients' diets are all over. And that could be. So there, these biomarkers are susceptible to so many different things. So unless one has some defined criteria, controlling for diet, controlling for living conditions, which are very difficult studies to do, and these are not prospective databases. I think these data are intriguing. They clearly tell us that there's more to it than just taking the values of either of these parameters at one time, that one needs to look at the values, and when they're fluctuating, there is something telling us that we need to do a better job of controlling it for the time being.
If you have interest in more information on these two trials, the one on LDL and this one we're talking about here with Dr. Deedwania on blood pressure, please see CardioSource World News. We have a news story in there, and I am the executive editor at ESC 2012.